Hi everyone, and welcome to episode 4 of Shine TV. My name's David Rossler, and most of you have missed out on a wonderful day that I've just had learning about a new technique, well, pretty new to me anyway. Some of you might know it, most of you will find this next episode absolutely fascinating. Now, aside from attending a great course today, I've had the happiness to deal with something that I guess we don't get enough of. When I say things like panache, timeless beauty, effortless grace and charm, I bet we all think of the same thing. We think of Italy. And with me today is Dr. Claudio Novelli, who of course is Italian, although he's plied his trade in Italy, in the US, in the UK. And it's a great pleasure to introduce Claudio to you, and I'm going to get him to talk a little bit about himself because I'm too envious to talk about it. Claudio?
Well, thank you, David. Thank you very much. As I say, I'm from Italy, from Florence, where I went to school. I received my postgraduate education there, and then I moved to California, to San Francisco, where I received my postgraduate education in aesthetic dentistry, and just best time of my life. Great time in San Francisco in the school, but I always want to go back to home. So I moved back to Italy in the 90s, late 90s, and I started doing practice in aesthetic dentistry in Italy, and that's what I do now. I work between Florence, Rome, Milan, and a little bit of Venice.
If only we could all do that.
I'm very happy. I was very fortunate, the privilege to work and live in beautiful places from San Francisco to Rome, Venice. I was fortunate, yes.
Okay. So I guess that gives you a special insight into aesthetics.
Well, yeah, I think that, living and working in beautiful places like cities, I said, it kind of gives you a little bit more sensitivity toward aesthetic. Like if you're growing up with so much beauty around you, I believe that your brain, or at least your eyes, become more sensitive to beauty. You see it better. And of course, aesthetic dentistry is much more than this, but it's a good point to start from.
Mm-hmm. Well, the thing I guess everybody's interested in is I'm actually interested in seeing some of these places that you live, so you promised me that you'd show me that.
Promise.
But then I'm also really interested to see we're doing Edelweiss, and I want to know what it can do and what it looks like. Okay,
well, Edelweiss basically are pre-shaped and pre-polished composite veneers. They came in a variety of shapes and size for direct bonding to the serving tooth. And the concept here was to give dentists and patients a new treatment options for aesthetic restoration smile frame. Because if we look at aesthetic dentistry over the last 10, 15 years, a lot of innovation, today I can bleach teeth, we can move teeth without braces, we can design a smile and have a CAD/CAM machine making it for us. But when it comes to restorative dentistry, aesthetic restorative dentistry, the treatment options are still limited. Actually, they are the same treatment options that I was offering to my patient when I started working and doing aesthetic dentistry 30 years ago. It was direct composite back then, or indirect ceramic, and today it's still direct composite and indirect ceramic. So what we want was to come up with a more updated, more advanced options for dentists and patients.
Okay. So what about you just before you show us something, I just should remind everybody that this is an interactive thing that we're doing, and if you want to ask questions, you need your smartphone, and if you go onto Shine TV, shine.tv on your smartphone, you can ask questions. And so with that out of the way, that little bit of housekeeping out of the way, Claudio, let's see a few of your slides.
Yeah, okay. Well, of course, this is home. This is where I say, this is, to me, I think this is part of aesthetics. It's part of where I live and part of what I do. And Again, I see patients from all the cities, and I do every kind of aesthetic work for them, including Edelweiss veneers. Actually, this is Venice, and this is a patient that I've seen recently. This guy actually is from Venice, and he came to me. He wanted to improve his smile, and his smile was not bad. You know, he had this rotated laterals, the centrals were not symmetrical, and he came to me and say, "Doctor, you know, because of my work, I would like to have a perfect smile." And I thought, well, maybe it's, you know, in the fashion industry or in the movies, who knows? So anyway, I discussed with the patient treatment options, and we decided to do Edelweiss veneers. So I prepare, actually I didn't prepare, I just decided to do Edelweiss veneers without preparing his teeth.
So what's the little black lines I see in the gum there?
The black line is a 000 retraction cord. It's a very fine retraction cord that I like to use. It's not necessary, but I like to keep it there to keep moisture out of the teeth when I do bonding. So that's what I like. So I took a set of Edelweiss veneers and I grind them inside with a diamond burr to make them very thin. This is something you can do with these veneers. You can make them much thinner than a ceramic veneers. And so I bond them with to his central incisor without any tooth preparation, and then I did the same for the laterals, and then this is how it looks now, and I think it looks good. And this was you know, very minimal invasive, very simple aesthetic dentistry. Patient is very happy with his smile. He finally has the, you know, the perfect smile that he asked for. So I asked him, "So, by the way, what do you do for work?" Because that's you came for that. Say, "Well, actually, this guy, he's not in the fashion industry. He's not in the movies. And this guy for Venice, this is what he does. He's a gondolier from Venice. It's a real gondolier. We don't have many of those." And so I was lucky. And actually, he was a very nice guy. This guy sent me this picture with a final smile and say, "Thank you, doctor. Now I have Hollywood smile, like the Hollywood movie star they have on my gondola." And so it was a nice patient, nice case. And actually, a few weeks later, I saw this lady. She came to the office, and she's her sister. And she said, "Oh, doctor, I would like to have a smile like my brother."
She's got his face.
Yeah, she's just as cute as his brother. Nice family, nice family. And maybe I'll see some other people from that family. But anyway, so she had a few aesthetic problems, and we decided to do full, complete smile makeover for her. Edelweiss veneers from second bicuspid to second bicuspid in a single appointment. So I had the laboratory preparing this positioning guide, so I could easily position the veneer right there where I want them. And I used the positioning guide to position the centrals, the first central, then the other central. You just prepare the tooth, bond it, and finish the margins. And and then I'm not gonna go through the whole thing, but this is how she looks now with all the veneers bonded. Here we go. So she looks very good.
Yeah, it's a great result.
Yeah.
But you know, you mentioned during that the veneers are much thinner than porcelain veneers.
Yeah.
Which you know, in my mind, you know, alarms go off, and I think, well, obviously this material is not porcelain. So, and you mentioned that it's composite resin, but I can't imagine that it's just average composite resin. So, I mean, it's important for me and the viewers, I guess, to know what are we talking about here?
Yeah, I mean, what really makes the difference with this technique is the material these veneers are made with. As you say, it's composite, but it's not like conventional composite. The whole thing starts from a homogeneous nanofill composite, and so it's nanoparticles only. There are no other particles, there are no clusters, there are no air bubbles. And what we do is we take this composite and we heat it at 300 degrees. And when composite reaches this temperature, it becomes very fluid, like water. And when it reaches this consistency, then we press it at 100 bars pressure, that's a lot of pressure, into the veneer mold. And here we finally do the curing. And we do the curing under vacuum. It's total vacuum, it's oxygen free. There is no oxygen here to interfere with the setting of the material. So there is heat and pressure process that makes the composite very, very, very dense and much stronger than a conventional composite, especially a direct composite. And then when the curing process is completed, this is what you get. This is a very, very dense composite restoration. And just to give you a comparison, you see on the other side, that's a conventional composite. And as you can see, there is almost no resin here. The resin is the black thing that you see in between the particles. So it's basically all filler particles cured under vacuum, 95% curing. And so this is, mechanical properties are very much improved. And then when the curing process is completed, the veneers cools off for half an hour because it's very, very hot. And then we do the laser treatment on the surface. The surface of these veneers are processed with a laser. And the laser beam goes back and forth on the surface of the veneer. And what this does is to heat the composite. So it doesn't heat through the entire thickness of the veneer, it's only the superficial layer, but the temperature is so high that if there is any resin, it evaporates and the filler particle melts. So here on the surface, what you have is 100% inorganic, means no filler, no resin, melted filler. So, and this is called laser vitrification, because what it does is to create a layer of melted silica on top of the composite shell, and melted silica, that's pure glass. So this is why you have composite underneath with improved mechanical properties, but you have a surface that looks very like ceramic. It's melted silica surface.
Sounds good. What about, fracture?
Well, the strength of this material, it's much higher than a conventional composite. Just to give you numbers, I mean, the flexural strength here is 200 megapascals. Now, 200 megapascals, it's twice the flexural strength of a conventional composite, and it's even higher than some reinforced ceramic like Empress One that we used many, many years for successful aesthetic restoration. That was 160 megapascals. So this is a very strong material.
And I imagine with that must give it a shiny surface, the laser.
The surface it's very glossy and very shiny. Actually, sometime when I show it to the patient, that's all they need to know. Just they see the glossy and shiny surface, very smooth, and just love it. And because they understand where is the potential for the material that's there. And it's not just glossy and shiny, it's also more durable than a direct composite. Than a conventional composite, either direct or indirect, the same composite that laboratory use. Because if you look at the surface of a conventional composite, what you find is a mix of resin and filler, and what happens to this mixture is that with time and function, the resin wears faster than the filler. So the surface slowly becomes rougher, and eventually composites start changing color and pick up staining. Now, on the surface of Edelweiss veneers, there is just this 100% inorganic melted filler. So there is no resin that could wear. There are no filler particles that could get released. So this is going to make this makes this restoration more durable. They're not going to age like a conventional composite. And this is what research tells us, that at least after 4 years of simulated functional tests, the surface of this veneers, the laser vitrified layer, is still intact, it's still there. And this is what I'm actually seeing in the clinical cases now, that are almost 6 years now that I've been using it.
So you've been doing this for about 6 years?
Yeah, I've been doing that for this technique for 6 years. Of course, like every new technique, at the beginning I was going slow because, it's a new technique. It's now direct composites, now indirect ceramics. So I really didn't know how, first of all, how they would look like, then how my patient would like them, could they fit in my practice, but then I was doing more and more, and I realized that my patient just love it, And I like it because it's very simple, it's not too expensive, it's very minimal invasive. So today, this is actually the most popular aesthetic restoration in my practice, more popular than ceramic, which I love, and more popular than direct composites, which I love.
And certainly much easier than direct composite.
Oh, way a lot easier. I mean, direct composite, it's a great technique, but involves a significant learning curve, and only a few dentists can master the technique and produce restoration with perfect anatomy, glossy surface. So that's the problem with direct composites. Of course, if you are Michelangelo, that's not your problem. But most of the dentists, they're not Michelangelo. And actually, very few dentists are Michelangelo. It's not just about being Michelangelo, it's about being Michelangelo every day with a single patient. So that's the main problem with direct composite. And that's why we came up with this concept of pre-shape and pre-polished composite restoration, because you don't have to do any polishing there. You still have the good things of composite. It's single appointment, it's minimal invasive, but the technically demanding and time consuming finishing and polishing, forget it. So now everybody can be a little bit of Michelangelo and makes perfect restoration on every single patient.
Okay. One of the things that appeals to me, and it's a question from our audience, is this that you've already answered really, that staining and discoloration are no longer factors here.
No, I mean, the surface is not going to stain like a conventional composite, because it's not conventional composite. And this is what I'm seeing at 6 years. And also what I'm seeing, yes, the margins are not going to stain.
Well, that was my next question, the margins. How do they do?
Well, the margins behave to me basically like a ceramic, and the reason why the margins are very good even after 6 years is simply because this composite is not sensitive to thermal stress, doesn't shrink and expand with hot and cold, so there is not much stress on the margin of the restoration. And the reason why it's not sensitive to thermal stress is simply because there is almost no resin inside, and resins will really shrink and expand. It's not the filler, so that's why margins are still very, very good after few years, 6 years in the mouth.
Okay, so how long do you think these things are going to, what do you say to your patients about how long they're going to last?
Well, you know what I tell patients? This is a new technique. I've been using it for 6 years now, and what I see at 6 years, they still look very good, so I know they have more years to go. How many more years? Well, ask me in 6 years and I'll have 6 or 10 years and I'll have an answer for you.
Okay.
But what I can tell you now is this is going to last longer than a direct composite.
Okay.
And this is what patient needs to know.
How about you show me another case?
Yeah, this is actually another of my favorite case, lovely lady. And she has a small peg laterals. And you could do this case in many different ways. You could do direct composite, that would be great. But still not so easy and not so durable. And patient must be committed to come back for polishing and finishing on a regular basis. Or you could do a ceramic veneers, and that's another nice option, but more invasive, more complicated, and much more expensive. Or you can do Edelweiss veneers. This is what I did for her, and this is still, single appointment, minimal invasive, and relatively inexpensive like a direct composite, but much more durable and stronger and better aesthetics like a ceramic veneer. So you can get the good things of both techniques, the good things from both worlds. From the world of direct composite, you have the single appointment technique, relatively short chair time, reduced number of clinical steps, and consequently reduced cost. And from the world of indirect ceramic, you have the beauty of the pre-shape and pre-polished restoration with nice gloss and nice shine.
And these ones, the laterals, they're prepless again?
Oh, these laterals were definitely prepless.
Okay. So what about patients like with crowding? Can you deal with teeth that aren't?
Yeah, actually, that's at the beginning, of course, like with every technique, I start with small cases, easy cases. And then when I realized that this technique was not that difficult and actually definitely easier than direct composite and easier than indirect ceramic, then I start stepping into more complicated cases like this young guy. obviously, severe aesthetic cases, and I did veneers, Edelweiss veneers from first bicuspid to first bicuspid, and still single appointment. Of course, it took some time, but you can handle even severely compromised cases with this technique. And actually, this was a case that I made a little over 5 years. So this is the picture I took at this guy at a recent recall appointment, and still very good. And you see the margins are very, very good. Margins look more like porcelain than composite margins.
I think that's a fabulous result. I really do. What happens, because eventually something's going to break or chip or something. Are these things repairable, or do you just throw the patient away? What's the deal?
No, I would repair them. No, I would definitely repair them. It's composite. It's
Yep.
composite. So it's not like ceramic. If ceramic breaks or chips, it's a miserable experience for the dentist and for the patient. This is composite, so you can repair it as it was a composite, or in the worst case, you take another veneer and replace it. They are there. You don't need to take impression. You don't need the laboratory. So, emergency and failure can happen. No one is perfect, but if it happens with this technique, it's easy to handle it.
We've got another thing that we haven't talked about, and I guess it's unfair to you.
No.
That we've been talking about veneers, and I think they're wonderful, but as a prosthodontist who is constantly changing people's vertical dimension, most of the time by accident, I have to admit, I'm interested in the fact that the system now includes posterior teeth, and I wonder if you'd tell me a bit about that.
Yeah, actually, this concept of pre-shape and pre-polished anterior veneer works so well that Edelweiss came up with posterior veneer, pre-shape and pre-polished posterior veneer to restore the occlusal surface of molars and bicuspid, and they are called occlusion VD. And they came in different shape. You have molars and bicuspid and different size, like the anterior veneers, and you use it just like the anterior veneers. It's actually an indirect restoration with proper shape, polishing, and size, but you bond it directly to the tooth in a single appointment. So again, you can restore the occlusal surface with a minimal invasive cuspal coverage restoration in a single appointment. Forget about impression, forget about laboratory, forget about rescheduling the patient for a second appointment. This is a single appointment technique.
That's great. Now when I look at the slide that Brett's going to put on for us again, I noticed that we didn't mention shade at all, and I look at those occlusion VD things, and they're very clear, and I know that the veneers are as well. So maybe we should talk a little bit about how you make these things coloured.
Yeah, one of the good things with this technique is that the idea was, if we make this veneers colorless, and they are made with composite enamel shade, so it's a semi-translucent enamel shade composite, then the color is very easy. It will be the color of the composite that you use to cement them. So if you cement them with A1, they will be A1, and if you cement them with A3, it will be A3, and you have that natural layering of dentin and enamel on top, and so it still makes it very, very natural looking, and shade matching will be much easier than with ceramic.
Okay, so we've got a system for anteriors and for posteriors made of basically a very good composite resin, if you want to look at it that way,
Very advanced.
that we're bonding to teeth. And I'm wondering, a couple of things. We've seen prepless ones. I want to know about the prep, especially when we're doing anteriors. And I want to see you put it all together. So how about I get you to do some sort of demo?
Yeah, we can easily do it. I mean, it's not going to take too much time. Actually, when I'm on a patient, to make one of these veneers takes me about 15 to 20 minutes from start to the end. So it's, I think we have the time.
Okay. So what do we got?
Yeah, okay. Everything you need for the procedure, it's here in this toolbox. In the toolbox, you have the veneers. You also have the occlusion and the composite that you need to cement it. So the first thing you have to do is, like with every aesthetic restoration, you select the color first. So you have this shade guide with dentin tab and enamel tab. that fits on the dentin. So you have A1, A2, all the typical dentin shades. So, and what you do, you just put
Wait it.
enamel here.
Should you be? I'm just wondering. Should you be wetting that?
Oh yeah, you should actually. It makes it more realistic, and so let's do it here. Okay, that's all it takes. And so when you put the enamel on top, it's very close to what you would see on a real veneer, because this enamel shade, this is exactly the same enamel shade that we use to fabricate the veneer. So this is actually like an actual Edelweiss veneers on top of the dentin. Okay. So this is what you see here is exactly what you get.
And how much effect does the tooth color that's underneath it have on the finished result?
Well, less than this restoration, they have better masking ability than alternative minimal invasive like conventional composite, and especially, unfortunately, indirect ceramic. So they mask the discoloration underneath better because it's a very, very dense material. So there's really not much that there's no space in between the particles, so the darkness from underneath cannot go through it. So that's what makes it a good masking material, very good masking material. So, but of course, this case we don't have any color problem, so we can use it doesn't really matter. I will use an A2, and actually I will also use some enamel, because you can use either one single color or you can use multiple colors. Mm-hmm. And like we do with our composite. So that's what I'm gonna do. But before, I have to choose the size of the veneers, because these veneers come in different sizes. And to select the size, you have this size guide. It's a clear plastic tray, and there's the outline of the veneer. So these are the small, these are the medium, and then there is also for the other sizes. So you just can bend it on the teeth and see which size fits your case. And I think this is a medium size. And of course,
so we're doing this by width or by length, or
you basically do it by width. But even if it doesn't fit exactly, it's composite, so you can make some small adjustment either in width or length.
Okay.
And so, but this case, I think it's just an M size. So I'll take an M size veneer, central incisor, and let's see how it fits. Of course, you can try it in the mouth, and if you don't like it, I mean, it's not the size you like, you can take another one, and these veneers that you try in the mouth, you can autoclave it.
Oh, that's good.
Yeah.
Is that after you've put them in the patient or before?
Depends on the patient.
Okay.
Okay, so this is, you see, size M fits nice. The only thing that I don't like here is that I would like it for this, well, let's call it patient, a little different shape. I would like it a little bit more tapered. Now, these veneers, they come in different size, but it's a single shape. It's a universal shape. It's a shape that was designed in a way that you can change it. And in this case, I wanted a little bit more taper. So I'm gonna make a little bit of adjustment here and here, just to make it a little bit more narrow there.
Now, just before, I'm gonna interrupt you. Before you start adjusting it, can you just take that off? Because you've done a prep on that one.
Oh, yeah.
And, I want you to tell us all, first of all, when you prep and when you don't prep, and what sort of prep you do.
Okay, when I prep, and again, I'm not prepping all the time with these veneers because they are very, very thin. So sometimes I don't need to prep. But when I prep, my prep is very similar to a conventional ceramic veneer prep. However, there are a few things different. Of course, it's less invasive, less preparation. I don't need that much thickness, and so I don't need much reduction of the enamel. Then I also keep my margins super gingival, as you see here. Actually, maybe you want to go a little closer, but for the purpose of this, seeing better, we kept it here. But you don't have to go with the margin under the gum line. Definitely you don't need that, because the margins of these veneers are just like blended composite, so you don't see it. So you don't see where the veneer ends and where the tooth starts. So you keep your margin super gingival, and also the veneer doesn't go in the interproximal space, so you don't have to extend your preparation there. So it's a very minimal invasive preparation. That's what I do. And sometimes it's no preparation at all, because you can make this veneer like 0.2, 0.3 millimeter thickness. So it's very thin, and especially when you do the full arch, like from bicuspid to bicuspid or canine to canine, veneers that thin, you don't need to prepare the tooth. It's reversible, very minimal invasive dentistry.
Okay, great.
So let's say, okay, this is fine, just want to adjust a little bit the shape. So I like to use a Softflex disc, that's what I like. But you can do it with other instrument if you like. Diamond burr, you can use diamond burr. But I just want to show you how easy it is. Because again, this shape was designed in a way that you can really make it. Okay, so that's all it takes. And yeah, I have a little more triangular shape. I like it better. Maybe I want to make a little bit more adjustment here. Of course, when you do this adjustment, you don't want to touch the laser vitrified layer. That's the glossy and shiny surface. You don't want to scratch it. If you scratch it, well, you can repolish it, but it's a waste of time. So just be careful. Now, well, you wouldn't do it with your ceramic restoration anyway, your glazed ceramics. So it's the same here.
Yeah.
So now the veneer is basically ready. And now this is a bonded restoration.
I just have to hold you up for another station break. If you want to ask questions, you can need your smartphone, shine.tv. We've had some really good questions so far, but I'd love to get some more. Okay, back to you.
Okay, so this is a bonded restoration, so you have to do some adhesion on the tooth side. You can do etch and rinse or self-etching, whatever you like to use. On the veneer side, on the inside of the veneer, you have to use the resin primer that comes with the kit. It's called Veneer Bond, and it's a resin primer. So you just use it like a resin. So
this is the magic stuff that makes these things bond.
yeah, because actually, if you use a regular BIS-GMA, regular adhesive, it will not bond to the inside of this composite veneer, because this is actually not real composite. I mean, when you bond to composite, regular composite, bonding is possible because there are double open link in the resin monomer. Here inside, there is basically no resin, and the little resin that's inside here is fully cured under vacuum, so there are no open links to double bonding. So if you use BIS-GMA, it will just not stick. So this resin, what it does is to reactivate the
Just
inside.
stop there. I'm going to interrupt you again. What happens if I don't just want a plain veneer? Is there any way I can stain this or anything like that?
Oh yeah, you can do it. These veneers, they already come with nice translucency, which is what most of the patient like. But if you want to have more translucency, you can either use, like I'm gonna do here, some enamel shade in the incisal third, or you can use a tint. The kit includes a blue tint that maybe with the camera we can see it. Maybe we can see it better on white thing. So it's a blue tint, but it's a very soft, gentle blue. So it's not, you cannot really over characterize it. And you can use it like, you know, any tint, and you can paint it inside like it was a painting. And you can add a little bit of translucency here. And so this is, if you want, you can do it. I don't do it too often because according to my experience, the translucency these veneers have, it's more than enough for most of the patients. But if you want to be more creative, you can do it.
Okay.
So, but I don't think this patient needs it.
No, I think
No,
they're not going to complain.
no, I don't think so. Anyway, I will be in Italy by that time.
Yeah, that's true.
So you just use the veneer bond inside, you agitate it for 10 seconds, you want it to react with the inside of the veneer. Okay, and then you light cure it for, here we go, for another 10 seconds. Okay, and the veneer is ready for adhesion. So now you just need to load it with composite. And again, I'm going to use 2 shades. I'm going to use a little bit of enamel and then some A2 Dentin.
And this is really where all the color's coming from.
That's where the color is coming from, yeah. And again, it's composite. It's not like ceramic. So shade matching, it's easier. It blends easier with a natural tooth. And we all know, I mean, everyone who has tried to do a single ceramic unit knows what I mean.
So you put some enamel up on the incisal edge.
Yes, because I want to have a little bit more translucency there. That's not really necessary. Even if you don't do it, the veneer itself already has some nice translucency. But sometimes, you know, you have a younger patient and you want to have more translucency. So that's what you do is you put some enamel there. You just create a little bit of mamelon and then you add the dentin. And you pull it with your spatula to the margin, so you have no bubbles there, no voids there. And then you're ready to position the veneer on the tooth, like this. Now you push it a little bit. You can push, it's not going to break like a ceramic veneer. Of course, you push it with a thumb, you don't push it with a pointed instrument or with a nail, but actually, you want to push it a little bit because you want to have a little bit of extra composite from the margins, because this tells you that you have no bubbles and no voids there. And then you remove that extra composite with a spatula, and I found that a tiny spatula, thin spatula like this one, it really helps a lot to remove the extra composite. You can push it a little bit more, like we do with ceramic veneers. You know, push, remove the extra, push, remove the extra until you don't see any more extra composite.
While you're doing that, I'll just answer a couple of questions. Some I know I can answer for you, but I'll let you answer others yourself. Can I cement the veneer with flowable resin? I'll let you go berserk about that one for a minute.
No way.
Horror.
No way. Well, no, I'm kidding. For 2 reasons. First of all, if you do this with flowable resin, the veneer will float all over. It will make it a miserable experience to remove the extra. And second, because these veneers are made to be bonded with a regular nanofill composite. This is what makes them stronger. And also, you know, these veneers are not fabricated out of an impression made and a model made out of an impression from the laboratory. So actually, do we have a mirror here? Okay, I can do this.
No.
Okay. Okay.
Bad luck.
No?
Actually, can you put that angle, the other angle on the screen for us, Brett? And
that will work.
there you go.
So you don't use the flowable composite, first of all, because then the veneers is not stable enough for doing the finishing. And reason number 2 is because, again, this is not made out of an impression. So you will have a little bit of bubbles, of voids along the margin, open margins. And if you have a flowable composite, it will definitely stain there, leak and stain. If you have a regular nanofill composite, it will behave after years like a tiny bit composite restoration on enamel margins, supragingival, so it will be just fine. So these are the reasons why you want to use the composite that's included in the kit, or at least a regular nanofill composite for bonding of these veneers.
Yeah. I mean, the other factor there, of course, is the ones in the kit are the ones that are making the shade. So you're going to get unpredictable results if you start using something else.
Yeah, it's shade coat, and actually, I mean, this composite that you have in the kit, you can use it also for direct restoration. It's a very good composite. It polished very well. It's virtually bubble free, and it's very chameleon-like, especially the enamel shade. I like it very much for my interior restorations.
And we have another question about if a tooth's damaged, hyperplastic or traumatized. Are you going to prep that for a smooth surface, or you're not really worried about the surface?
No, I mean, you're not gonna take an impression, and you're not gonna send the impression to the laboratory. The laboratory's not gonna work on the model, so you really don't need that, super finish and super smooth margins and perfect preparation. Of course, you still have some requirements, but you don't have to spend too much time preparing this tooth. It shouldn't take you more than 1 minute or 2. So even if you have a rough surface, it will still be just fine. So can we go back to the lingual? Okay.
So I need to just mention to our audience that you were doing demos for us today, and but without having all these hot, strong lights on for the video, and so I know that this composite has gone much stiffer than it normally would be, which is making your life a bit difficult. Mm-hmm. But you're coping.
Okay, yeah, we can go back to the link to regular view.
So now that's a particular instrument you're using to remove the excess. What is that?
Well, this is an IPC carver. It's called interproximal carver. This is because this is what you do. You can go interproximal, and especially if you wet it with alcohol, like I was doing, it makes it very easy to clean the extra composite. So I think this is it for the buckle. Mm-hmm. Okay, so I can now, position is fine. Of course, you want to double check the position before curing this veneer, because once it's cured, you have some margin of adjustment, but not too much. So position, I think, is just fine. I have my incisal edge where I want it. I want it a little bit longer than my canine. So this is where I want it. And so I think I can go with curing it.
Now, if you were doing, say, all 4 upper incisors, would you prep them all and then do them, or prep one and do that, or what sort of sequence do you use?
Well, the first time I think it's easier if you do one by one, because then you have the other teeth as a reference for positioning. Mm-hmm. But now, no, I do them all at once.
Okay.
So I can cure it. Usually my curing time is 40 seconds. And now all I have to do is finishing. And of course, again, you don't go with your finishing instrument on the buccal surface, on the glossy and shiny laser vitrified layer. Just do the finishing on the composite around the margin. And if you have been good at removing the extra composites, this is going to be very easy and quick, like finishing a class 5 composite restoration.
So we have a question about, can you modify or characterize the surface, and how do you polish it if you do? I think you can answer that.
Well, the surface of this veneer already has nice anatomical features. They have concavities and convexities, so you really don't need to change it. Everything is already there. So no, I wouldn't do it. No, I wouldn't do it.
Yeah, and if you want to characterize color-wise, you do that from the inside, not the outside.
That's right. The outside of this veneer is what makes it so nice, glossy and shiny. So you really don't want to touch it. Like ceramic, I mean, that's what you would do.
Yeah.
Or you wouldn't do.
Yeah. And this, what you're doing now, is basically the same as you do with any veneer.
Exactly. So you just finish the composite around the margins, so it shouldn't take you too much time.
Now, although you don't characterize the surface, if the incisal edge is a little bit long, you have no problem trimming that back if it's required?
No, there is no problem. Just be careful when you do it to hold the disc or whatever you use in a way that you don't touch the buccal surface. But ultimately, this is composite, so you do have margins of adjustment. You just don't want to adjust the buccal surface because has already been done for you.
Yep, yep. Now, what about when when you're doing one, that's one thing. When you're doing multiples, how do you stop ending up with a 6-unit bridge? How do you avoid connecting them all? Do you use a matrix? Do you use a mylar strip, or what do you do?
Well, that depends whatever works in your hands. In my hands, mylar strip, they don't work very well, but most of the dentists, they like to use mylar strip, and that's what you would use here. It was a direct composite. I like Teflon tape, that's what I like. But I know dentists who use mylar strip, and it works very well for us. So I would say,
just for the audience, I'm
yes,
putting a piece of Teflon tape in front of them.
This is a Teflon tape. You just pull it in between, and it's very, very thin, so it doesn't interfere with the interproximal contact. And of course, composite doesn't stick. So it's an alternative to mylar strip. I like it because it doesn't get in the way. But again, this is you can do however it works best for you.
Mm-hmm. And then I can see now you're just finishing them with normal composite resin finishing strips.
Yes, the finishing is it's just like you were finishing direct composites. It's what we do every day. Well, and basically, here you go. You have a nice restoration with very glossy surface, proper shape, and it doesn't really take too much time. And it looks as good as a ceramic restoration, but still takes you only one appointment and a very minimal invasive preparation.
Okay, well, thank you very much for that demo.
Thank you.
Now, I'm not letting you off the hook just with that. I want to see another human.
Okay, what we have here. This guy actually, it's an occlusion guy. It was a guy that I made. Actually, I made both occlusion and veneers. I made so many cases now, sorry, that I kind of forget what I did.
Yeah.
But I remember this guy now because he came for this problem. Severely worn lower teeth. And because of this deep bite, there is no way to restore these teeth, at least with a minimal invasive technique, unless you raise the vertical dimension.
Well, now, I just got to stop you. I hate lower incisors. I think they're just a mistake and people shouldn't have them to begin with.
Well, that's an interesting point of view.
But so this technique, we can use this for lower incisors?
Yeah, Edelweiss veneers, they're available as upper veneers and lower veneers. Actually, I like it for lower veneers because ceramic, I think, is a very, very aggressive technique for lower teeth, and there's also an issue with hard and rigid bonded ceramic restoration opposing the natural arch. So composite is more kinder material, less hard and rigid, and this composite is still very, very strong, so it will behave very well even under heavy compressive stress. So this is a good material for lower anterior teeth if you like them.
Yeah. Yeah, if you don't want to get rid of them.
You will do it.
Yeah. So I've got a couple of questions here, and they're similar in some ways. But repairs, we've had a question about repair. But can you just take us through? Someone's chipped one of these, cracked one of these. Well, not cracked. Let's say they've chipped a bit off. How are you going to repair? Just take us through the technique of repairing.
Well,
how do we deal with the surface and everything?
Hopefully it's not going to happen. But everything we do in the mouth might break.
Yeah.
So. But again, if it's ceramic breaks, it's a problem. With this is composite, so it's easier to handle it. Now, the secret is this. In the kit, you have the enamel shade. Again, this is exactly the same composite that Edelweiss veneers are made with. So this is the composite that you're gonna use. If a corner, a little piece chips, you just repair with this and you will not see any difference because it's the same shade, same composite.
But how do we bond to that surface?
Well, you bond it like you would bond to any composite restoration. So you roughen up a little bit and Again, you do not use the regular adhesive, but you use the veneer bond, that's the adhesive that's included in the kit. And then you just lay down the composite and finish in with like it was a small composite addition. And that's what I do if an emergency happens, and if it's a small chip-in. If it's a bigger chip-in, well, you can always take another veneer from the box and replace it. It takes you 15 minutes, so it's not a big deal.
Yeah. Okay, well, and we have a question about wear, but I know this case you're showing us has wear, so let's have a look at this case.
So again, I decide that I need to raise the vertical dimension for this patient, otherwise there is no way to restore this teeth with a minimal invasive restoration. So I decide how much I need to open the vertical dimension. I'm not going to go through this now, but what I want to show you is this is what I needed, 5 millimeter on the vertical pin, and of course I fabricate a bite at this new vertical dimension for the patient to wear every day, 24 hours a day, only when he eats and he doesn't wear it. And so this is basically the test of the new vertical dimension to make sure that its patient is comfortable. And some patient, they wear the bite for a few weeks, somebody for a few months. That's very dependent. But when the patient is comfortable, I know that I can move on with a new vertical dimension with occlusion BD. And in this case, I decided I want the laboratory to fabricate the veneers for me, the occlusion for me. Okay, so basically the laboratory takes the veneers, realign them at the new vertical dimension, and what I do, I like to give the laboratory the mounted model, of course, but also the bite. The patient gives the bite to me and I give it to the laboratory, so they exactly know what vertical dimension I need. And so then the laboratory gives me the occlusion reline at the new vertical dimension, and from here on it's just like cementing a normal bonded restoration like they were always. So that's what I did for this patient. And you restore one arch and then the other arch, and then now I had the space to restore his lower teeth with minimal invasive veneer restoration. These were occlusion on posterior and Edelweiss veneers on the lower anterior, and maybe we'll do some veneers on the upper in the future.
And how long do you think those lowers are going to survive? What's your prediction?
My prediction, it's science, is what I see. 6 years now and more years to come, but I don't know exactly how many more years. We'll see. But that's with every new technique. But definitely they will last longer than a ceramic, than a composite restoration.
Okay. Well, I mean, that was a pretty dramatic case. What about with like a single tooth? And especially, sorry, Claudio, contact points. What do we do about contact points?
Well, contact point, if it's a case of vertical dimension, you don't do anything. You just keep his original contact point.
Sure.
That's very easy. If it's a single tooth, like a tooth like this one, then it's a cuspal coverage restoration because the residual wall are too thin, then you build up the distal contact point with direct composite, and then from there on you just go with the regular technique. So you select the size of the veneer, then you prepare it like it was an onlay. And my trick here is when I do my preparation, I use a rubber dam, of course, and I put a clamp on the most distal tooth. That's a 26 NU 3D clamp. It's a very shallow clamp, as this one here. So basically now I can have the patient biting with the rubber dam still on.
I got to tell you, that is so cool. I use rubber dam for everything, and I've never thought about, patients constantly bite, but they never get their teeth together.
Yeah, you can do it. When I did it the first time, I say, well, try to bite it, and I thought, well, it's gonna bite on the clamp, and then I realized no, because this 26N clamp is very, very shallow, and if you do on the second molar, it will be okay. So now you can what you do is just you bond occlusion with composite, and you can even have the patient biting on on the occlusion, and basically the patient is going to sit the occlusion at the proper vertical dimension, and then you put back the rubber dam the regular way, and you do your finishing and curing, and this is what you get. Minimal invasive cuspal cavity restoration with very nice anatomy and fabricated with a composite material. This is much stronger, much better performance than a conventional composite, or a composite that the laboratory used to fabricate only, because that's exactly what we use in the mouth.
Great,
Correct.
great. Now, I want to go back. There's a question about, with the big cases, what occlusal scheme do you use?
Well, I like to have, my main concern is that I don't want to have lateral interference on my anterior restoration and anterior teeth. So I have canine guidance and no lateral interference on, at least when I have bonded restoration on the anterior. That's my guideline.
Okay, great. Now, I have a personal interest. A lot of my patients have erosion problems, and this seems like you might be a nice technique, and I was wondering if you could show us something about that.
Yeah, I mean, we are having erosion all over the world. Even in Europe, we are seeing more and more erosion things, and sometimes it's just because, well, teeth wear, and teeth wear are not supposed to last so many years in the mouth. So to a certain extent, that's natural, but in many other cases, no, it's not natural. It could be either perfunction, it could be gastric reflux, or could be bad dietary habit. This patient, she was bad dietary habit, and she has this severe erosion on the buccal, and this is a perfect case for Edelweiss veneers, because case like this, you just don't do any preparations. Make this veneers very, very thin, just bond it, and it will be purely enamel reconstructive technique. And you know, what else can you do for her? I mean, it's not gonna be a ceramic veneer case. The alternative would be either direct composite, but not very long lasting, or very aggressive ceramic with probably root canal. So I decided, well, let's do Edelweiss veneers. I made them very, very thin, and then I bonded, and then she's happy now. She's happy.
When you say very thin, first of all, how thick do they start off life, and how thin do you make them?
Well, they fabricated at a thickness that's about 0.5. It's a little thinner in the gingival third, it's a little thicker in the incisal third, but its average is 0.5 millimeter, which is already kind of thin veneers. It's thinner than most of the ceramic veneers. But you can take the diamond burr and grind them, because it's a very strong composite. You can grind them very, very thin without cracking. And I would say, about 0.2 millimeters. That's
Okay.
very thin.
Yes, it's very thin. And does that affect the way they look?
No, I mean, I've been doing some regular thickness veneers and some ultra thin veneers, and I don't see any difference in the way they look, and no difference in the way they perform at 6 years.
Oh, great. Now, you mentioned at the beginning that you do composite resin veneers, and you do this, and you do porcelain veneers. And how much now? How has it changed? I know you're doing this more than anything else. Could you put percentages on it?
I would say that out of 10 patients in my practice, and again, my practice is focused on aesthetic dentistry, so patients come to me for an aesthetic treatment. And I would say out of 10 patients, 6 are Edelweiss veneers, and 4 are either ceramic or direct composite, so quite a lot.
That's great. I have one last question.
And my life
for
is
you.
much easier now.
Well, that's even better. I have one last question, and it's something you covered during the day really well. But with patients with recession or really long teeth, obviously you don't make a super long veneer. What do you do with that?
Well, of course, I mean, to a certain extent, you can make the tooth a little shorter, but you don't want to shorten the incisal edge too much, because then you lose teeth visibility. So at the end, you will get with Edelweiss veneers and some class 5 composite at the end. And what I see is that over 5-6 years, this class 5 composite at the end of this Edelweiss veneer, they behave much better than regular class 5 composite. So there is less leakage and less staining.
I promised that was the last question, but there's one more that we haven't covered and you might not be able to answer. How much?
I might come back to Australia.
What does it cost?
Cost is in between composite. It has to be more expensive than composite because it's a valuable, more durable restoration. There's the extra cost of the veneer, but much less than a ceramic because you don't have left fee and it takes only one appointment. So it's somewhere in between.
Dr. Novelli, I want to thank you for a wonderful day and a really enjoyable evening.
Thank you. It was my pleasure.
It's our pleasure. Now, for those of you who want your CPD certificate, the instructions are on your screen. And if you slip a little $10 note in there, we'll give you 2 CPD certificates. Thanks very much for listening to us.